Good afternoon, ladies and gentlemen. A very warm welcome to our event during the European Public Health Forum. And I'd like to invite you, or first of all, I would like to thank you that you followed our invitations to this event. And I think you've got some very important information for the future of our international and national health systems. And we are very proud and thankful that we have some speakers here, which I would like to invite to you right now. First of all, I would like to thank Angelika Wittheim, the chairwoman of the Hepatitis Aid Austria, which is at the same time the host of this event. And then we have the Professor Dr. Markus Pek-Radosajewicz. We have Professor Docent Dr. Thomas Dorner, the guy up there. And we have Dr. Hans Haltmayer. And they will explain their topics by themselves at the time. And first of all, I'd like to ask Angelika for your intro statement to this event. Please, Angelika.
Thanks, Martin. Thanks a lot. Hello. Dear speakers, dear ladies and gentlemen, dear guests, dear colleagues, and other patients groups. And last but not least, thank you, our sponsor. My name is Angelika Wittheim, you have heard it, and I'm the president and founder of the Hepatitis Aid Austria, and I'm also a member of the board of from ELPA, the European Liver Patients Association, which is based in Brussels. In your invitation, you will see that I share the chair of this panel with Dr. Stanimir Hasojiev. He is board member of EPF and general secretary of the Patient Access Partnership and chairman of the Bulgarian National Hepatitis Organization, Hepasist. Unfortunately, Dr. Hasojiev had to cancel his participation, so I now transmit his short welcome speech to you that we received from him. Hello, my name is Angelika Wittheim. I'm the president of the Hepatitis Aid Austria, and I welcome very well Dr. Stanimir Hasojiev. He is a member of the board from EPF and the general secretary of the Patient Access Partnership. Yes, please, Dr. Hasojiev, would you be so kind and talk us something to us?
First of all, thank you very much for the invitation to co-chair this meeting. As board member of the European Patients Forum, I've always put efforts to support patients and patient groups around the world when they want to improve healthcare in their own countries, when they want to make the systems more patient-friendly, and when they want to achieve more for the good of the nation. Therefore, I think today's meeting is an extremely good example of patients and doctors cooperating and talking about extremely important topic, which is eradication of a disease that recently was considered to not be treatable. Nowadays, the world is changing, and I think all of us have chances with joining efforts, doctors, patients, society, and governments to achieve much better situation in our countries. It's a problem of everyone, therefore I do believe that the solution would come if only everyone sits around the table and trying to find this solution. Therefore, in my capacity as Secretary General of the Patient Access Partnership, which is a broad platform bringing together doctors, patients, politicians, industry, is aiming actually to contribute for development of new models of cooperation that will increase access, that will improve situation in different countries. Hepatitis C is probably the perfect example for that. In order to eradicate this disease, Of course, we need advance in science, and we already have it. We have enough new medicines that work perfectly and very fast and safe for most of the patients. But are we there yet? Are we close to the eradication of hepatitis C? Having a medicine has not always been enough. If you don't have the right doctor to make your diagnosis, if you don't have the right diagnostic facilities, if you don't have the right healthcare professional to advise you to do that, if you don't have the right team to take care for you, you would probably not get the medicine and you would probably not be treated. When we add on top of that the support that the patient needs to receive, the adherence to the therapy, which is extremely important in this case, we can see that hepatitis C is an example of a disease that needs a holistic approach. Therefore, access to all these services, from the information, prevention programs, early screening, timely diagnosis, and timely treatment, are extremely important for this disease. Therefore, I think only the cooperation of different experts, not only doctors and patients and politicians, but also experts in other fields, also the pharmaceutical industry has to contribute enough, are the only way that we tackle this disease. Programs are needed in all countries, strategies that will put timelines, that will put responsibilities to the different parties, and this is the way that we someday might talk about eradication. Cooperation is the key. Therefore, I would wish success of today's meeting, and I'm sure that today's meeting will bring Austria one step closer to the eradication of hepatitis C.
Chronic non-communicable diseases, as well as infectious diseases, still remain a huge public health challenge. Although new lifestyle or medical approaches showed great effects on various health outcomes, there is still insufficient access to sustainable prevention programs or contemporary therapies of many diseases for vulnerable groups. It is the access to sustainable prevention programs that has to be improved. But often there are not even simple prevention programs or strategic plans. Furthermore, also the fact has to be highlighted that we have to face the challenge of the current demographic change. But the most important thing with all these issues is to always remember it is not a disease, it's the human being that should be looked after. That's the most important thing. Today, the focus will be on frail people whose quality of life can be improved significantly with physical training and nutrition optimization. The President of the Congress, I welcome you very well, Professor Dr. Thomas Dorner, will deal with us these topics. Fine, thank you. Afterwards, Dr. Hans Haltmayer, representative for drug addiction issues of the city of Vienna, will talk about reducing disadvantages in daily life for people with addiction diseases. And finally, we will hear a lecture from Primarius Universitätsprofessor Dr. Markus Peck. With the title, There is no reason to suffer any longer from viral hepatitis. Our aim is to recognize all the different possibilities presented by these experts. After the lecture, we kindly ask you for your contribution for the discussion to start a strong initiative to reduce health inequalities for vulnerable groups in the public health systems. I thank you for your coming, and I invite Professor Dorner. Please, would you be so kind?
I'd like to talk about lifestyle intervention at home, physical training, and nutrition optimization for community-dwelling frail people delivered by lay volunteers. So I want to talk about frailty. What is frailty? Frailty is a geriatric syndrome, consists of 3 parts. It's sarcopenia. Sarcopenia means loss of muscle mass and loss of muscle function. It's malnutrition, especially energy protein malnutrition, and it's chronic inflammation. And those 3 pillars of frailty are interrelated with each other. So if people suffer from sarcopenia, they are likely not to go out anymore. They are likely not to have enough food in their refrigerators. This leads to malnutrition. Malnutrition, especially protein malnutrition, leads to the fact that the body protein is used for very important body function. So malnutrition leads also again to sarcopenia. Malnutrition is associated with chronic inflammation, and there are chronic inflammation markers which have a catabolic effect and also enhance sarcopenia. So those inflammation markers also leads to loss of muscle mass and loss of muscle function, and that's the circle of frailty here. So what are the risk factors for development of frailty? The risk factors are genetic and constitutional factors and also environmental factors, especially sedentary lifestyle, unbalanced diet, and living conditions. We have many physical facts associated and risk factors for frailty. We have social risk factors, and we have also cycle risk factors for the development of frailty. Here again, we have the 3 pillars of frailty: malnutrition, sarcopenia, and chronic inflammation. And the characteristics of frailty are loss of muscle mass, loss of muscle strength, low physical performance, loss of endurance, and also insulin resistance. This is frailty. What are the consequences of frailty? The consequences of frailty are severe, both for the individual as well as for the society. Consequences of frailty is vulnerability, especially vulnerability for diseases, for infectious diseases and chronic non-communicable diseases. Disabilities, loss of activities of daily living. The risk of fall is increased, the risk of morbidity is increased, risk of hospitalization, nursing home admissions are higher in frail persons, risk for mortality is increased, dependency is increased, social isolation is decreased, and the quality of life is decreased. And also for the public health, for the community, frailty leads to healthcare costs, to increased healthcare costs. So I think frailty is, due to the demographic development in our societies, one of the major problems and major challenges for public health and for our society. You know, the recommendations for health-enhancing physical activity, here is a picture of the Austrian recommendation for health-enhancing physical activity, which was developed by a competence group within the Austrian Public Health Society on behalf of the Federal Ministry of Health in Austria and Volksbundes Österreich. And here you see it is important for health-enhancing physical activity to have at least 150 minutes of physical activity of at least moderate intensity, and additionally twice a week strengthening activities, so muscle resistance strength training. And this is valid for all adult individuals, and is also valid and especially valid for elderly people. And in this picture we have not forgotten of the elderly people. They profit most of that, and they profit so much from this strength training and resistance training. And this is one of the important things to deal with the problem of frailty. In the Medical University of Vienna, we launched a project where we wanted to cope with the problem of frailty. So it was a randomized controlled trial where we had frail people in different groups, in 2 groups. One group was visited by volunteers, by lay volunteers which had a special education for that, and they performed twice a week physical activity and strength training. And we had a control group also there, and in the control group they also visited twice a week the frail people, but they didn't perform a physical activity training together with them. So it was just social support. And the other group, the intervention group, was physical activity and training, nutrition intervention, so they were talking about nutrition problems, and also social support. So these are the 3 parts of this project. So it was a randomized controlled trial. The active part was carried out between 2013 and 2015. We had volunteers, the buddies, which performed the physical activity. They had to be at least 50 years or over. And we had the frail people, which had the inclusion criteria. They had to be older than 65 years, living in Vienna, pre-frail or frailty according to the Share Frailty Index. They had to be community dwelling, so not being in a nursing home, so they had to be living at their home. And they had to be able to walk and no medical contraindication. So then we had this randomization. We had the control group, which were 41 couples, and we had the intervention group, which were 39 couples. And for 12 weeks, they performed the visits and nutrition intervention in the intervention group, and the strength training in the intervention group, and control group, social support only. So these were the things we developed for this project. So yeah, we had a booklet and we had a calendar for physical activity. That's what the intervention for physical activity looked like. So we had a circuit which was performed twice. The circuit consisted of 6 specific muscle strengthening activities and training programs. That's what it looked like in real life. So we have here the frail subject and we have the buddies, and together they performed the physical activity training, here with the TheraBand. First, we wanted to pick up the frail people where we thought they are really, and this was in the hospitals. So we went to the hospitals, we introduced this project to the frail subjects, and we screened almost 300 subjects for this project, and out of this almost 300 people, only 2 participated in the end in this physical activity or health promotion program. So this was one lesson we learned. Recruiting frail people in the hospitals did not work at all. What really worked was one film about the media. It was a report in the Austrian ORF, and actually the redactor who wrote this is actually here in this room, and who made this film. And after this film, many people rang us up and said they wanted to participate in this training program. So afterwards they were randomized, and after 12 weeks the first assessment was performed, and the comparison between the active group and the social support group was done after 12 weeks. So these are the most important results. The frailty status. Here you see the intervention group in blue, and you see the control group in violet. And the frailty status measured with the Share Frailty score declined in both groups, and especially in the intervention group, the frailty status declined very impressively. Also, the nutritional status increased in both groups, but nutritional status increased more in the intervention group compared to the control group. Another very important effect of this program was the hand grip strength. The hand grip strength increased in the intervention group by more than 2 kilograms, which is a significant and important increase in muscle strength. And also quality of life increased in both groups, but it clearly increased more in the intervention group compared to control group. So social participation and social support also increased quality of life, but when coupled social support together with physical activity and training and nutrition intervention, this had a clearly better effect than social support alone. We also saw effects in the buddies. Here we saw a clear increase in hand grip strength in the first 12 weeks and also in the next 12 weeks. And we also saw a clear and significant increase in the strength of the lower extremity. So here we saw increase in the leg press also by almost 10 kilograms, which is quite a lot, in the buddies. So the buddies were the not frail, the robust elderly people, which were at least 50 years or older. So the conclusions, We performed a nutritional and physical activity intervention and social support, and in this group there were significant improvements in outcome parameters, and those results we saw were quite comparable to results which are achieved by health professionals. But compared to health professionals for public health and for the health budget of the society, when it is performed by volunteers, of course, it's much cheaper than it would be if it would be performed by health professionals. We had also effect in the social support alone group. Here we saw a tendency to improve outcome parameters, but not that much as in the physical activity group. So this is a novel, cost-effective way to promote health in pre-frail and frail older community dwelling adults. And also, we could improve some outcomes in the bodies. Thank you very much.
Thank you very much to the chairs, and I will welcome you. I will give you some information about a new concept, a concept in Vienna for reducing disadvantages in daily life for people with addiction diseases. We did it by treat opiate-addicted people against hepatitis C infection with DAAs, with modern DAAs, with direct-acting antivirals. And I will show you some data about this. We collected, me and my colleagues from the Dialog, it's another drug treatment facility in Vienna, and from the Wilhelminenspital, it's a hepatological center in Vienna. So, first, my disclosures. A part of this project was supported by Gilead Sciences. I have no conflicts of interest. Some background information. In Austria, we are talking about 30,000 people suffer from severe opiate addiction. In Vienna, about 10,000 people. And among them, about 1/3 are people who inject drugs, and you know, most of them, the transmission, the common way of HDV transmission is injecting drugs. So it doesn't wonder that the prevalence of chronic hepatitis C is very high among this population. It's about, the infection prevalence is about 60 or 70%, and of them about 40 to 50% are not able to clear the virus, so they develop a chronic hepatitis C. Most of them not only suffer from hepatitis C, they suffer even from psychiatric comorbidities such as phobia, depression, psychosis, and anxiety issues. So many of them feel excluded or unworthy of medical treatment, and therefore they are reluctant to or incapable of seeking medical treatment from general health care services. And many of them live under very poor social circumstances. A lot of them are homeless, unemployed, they have unstable social relationships, poor living conditions, or have been in prison for several periods. Here the data again, you can see the prevalence of hepatitis C in this group, HDV antibody positive and present of hepatitis C virus. And we focused on this group and were looking for a setting to treat these patients with DAA. And you have to know that the state-of-the-art treatment of opioid addiction is opiate agonist treatment. You substitute illegal opiates and give them opiate as prescribed medication. And so opiate agonist treatment or opiate substitution treatment is the state-of-the-art treatment of opiate addiction. And this group is a special and very important subgroup of pivots, and we are focusing on them when we developed our concept. So we defined 3 groups of patients. Patients with good compliance. These patients adhere to their scheduled visits in outpatient clinics. They ingest the pills as prescribed. They have a good social integration. And these patients can be treated at the outpatient clinic of hepatologic centers, for example, the Wilhelminenspital or the internal department in Klagenfurt, where Professor Beck is. So these patients are not the problem. In opposite, there is a group with patients with poor compliance. You see it at the end, group 3. These patients do not adhere to their scheduled visits, neither at hepatologic centers, not at low threshold drug treatment facilities or pharmacies. And they even don't take their opiate agonist treatment on a regular basis. And we are sorry, but at the present, antiviral treatment is not possible in this patient group. But there is a large third group. We called it patients with borderline compliance. And these are the patients I was talking before. These patients reluctant to go to specialized hepatologic centers, and they suffer from psychiatric comorbidities. They had a lot of contraindications against interferon-based treatment. The social integration is very poor. Most of them are homeless, are unemployed. If you would prescribe an antiviral regime, they would not take the pills on a regular basis. But in contrast of this, their compliance is excellent with respect to their opiate agonist treatment. They never would forget to take their opiate medication because otherwise they would get withdrawal symptoms. So this setting is very stable, and this was the backbone of our new concept, the directly observed therapy together with opiate agonist treatment at a low threshold drug treatment facility. Here you can see the low threshold drug treatment facility. It's the Sucht Wien. You can see here it's a day center. It's a syringe exchange possibility. Here we have an outpatient clinic, and here we have a night shelter with 26 beds for homeless drug addicts. And it's located in the center of Vienna. In this low threshold outpatient clinic, we offer different activities, drug addiction counseling and treatment, all of this without charging. opiate agonist treatment, general medicine, free of charge vaccination, and we even work together with some specialists. We have a outpatient clinic for treatment of hepatitis and even an outpatient clinic for treatment of HIV and AIDS infection, and so on. We do this together in a Viennese HDV treatment network. These are our partners, the staff of the Suchthilfe Wien and the Verein Dialog, and even the Wilhelminenspital as the specialists for gastroenterology and hepatology under the lead of Michael Gschwantler. For treatment, we made 2 cohorts of patients. Cohort 1 was a non-interventional study supported by Gilead. It's closed now, and we are writing the paper. Inclusion criteria has been genotype 1, treatment-naive patients, no cirrhosis, HIV, no HIV and HPV co-infection, and 8-week duration of treatment. And the cohort 2 was a treatment within the reimbursement policy of insurances. You know, this is changing over the time. We treated all genotypes at a minimum fibrosis stage 2. Patients with cirrhosis were included, and the individual treatment regimes were done according to the genotype, fibrosis stage, pre-treatment, co-infection, and the current reimbursement policy of insurances. So the data I will show to you are these 2 cohorts together. Till Tuesday this week, we have treated 74 patients in treatment, 3/4 male, 1/4 female. The most common genotype is genotype 1, and then genotype 3. 21 patients had liver cirrhosis, and 5 patients even had a HIV co-infection. One main focus was on the adherence to therapy, because as I told to you, everybody, and especially our patients, forgot sometimes to take their medication. But this group never forget to take their opiate addiction medication. So the special thing on this concept was to replace opiate agonist treatment during the treatment of the HIV from the pharmacy to our low threshold facility. And the patients got their DAA treatment of chronic hepatitis C together with the opiate agonist therapy under the direct observation of a physician, mostly of a nurse, at the outpatient clinic in our low threshold facility. Only in exceptional cases, the drugs are given to the patients for self-administration during the weekend. For example, when they visit their parents or their children during the weekend, we gave the medication for self-administration. And following the concept of this directly observed therapy, the adherence was excellent. You can see only 6 scheduled dates out of nearly 6,000 were missed by these 74 patients. That means 0.10%. And remember, this is a difficult to treat community. And in this community, it is possible to gain such excellent adherence. And when you look at the virological outcome of the therapy, 53 patients completed therapy and 12-week follow-up. We have a SVR, sustained virological response of all of them of 100%. We had no relapse and we had no loss of follow-up. So I come to my conclusions. This concept, directly observed therapy of chronic hepatitis C with DAA at a low threshold drug treatment facility represents a promising new concept for treatment of patients with borderline compliance receiving opiate agonist treatment. And it is a promising new concept for treatment of disadvantaged patients who would normally be excluded from medical treatment against hepatitis C. And this successful treatment of these patients is beneficial for themselves, but not only for themselves. By successful treatment, further transmission of this virus may be also prevented. So let me say thanks to my team at the Suchthilfe Wien, the Verein Dialog, the Wilhelminenspital, and last but not least, to Gilead Sciences. Thank you very much.
So yes, thank you very much for inviting me here. I will actually not be able to show you any own data. I will just give you an overview of what I think is important with regards to viral hepatitis. As you, well, I do have some disclosures, and other than Dr. Haltmayer, I am biased towards drug treatment of viral hepatitis. So, but that's the reason for this talk here. So, burden of hepatitis C and epidemiology. I think you're all well aware of this. There is a relevant number of people infected, at least in Europe. You can see that here. The color gives you the frequency, and the size of the dot gives you the absolute number of infected people. And you can see already where the real trouble is non-European countries. And in Europe, of course, you see those major countries that have the highest burden of hepatitis C infection. Now, global prevalence in injection drug users is probably well known to you, and I will not go into that because Dr. Haltmayer already alluded to that. But from the global burden of disease study, we do know that cirrhosis and liver cancer is something that on a global scale is actually still increasing. And you can see here deaths due to cirrhosis are the ones in dotted lines, different depending on etiology. So blue is hepatitis B, green is alcohol, and red is hepatitis C. And you see that there is a steady increase in death due to cirrhosis as well as in death due to liver cancer, which is actually a consequence of cirrhosis. Also, deaths attributable to HIV and viral hepatitis, when you compare it, you see here, this is just the European data, Western European data. You see that it is fairly stable, but still slightly increasing with regards to hepatitis C. I would say stable with regards to hepatitis B. And contrary to that, at least the death rates due to the HIV have been decreasing due to the wide availability of very effective antiviral drugs. And the reason why I'm showing you this is because today we do have the same type of very active drugs against hepatitis C, at least. We also do have against hepatitis B, but because we're not actually finding all the patients and we're not treating all the patients, we don't see this dramatic decline here in viral hepatitis related deaths that we do see for HIV related deaths. And here when you look at it and look at the difference between chronic viral hepatitis and liver cancer, you see that most of the increase still is due to liver cancer, which is one of the late stage problems associated with viral hepatitis. Now, natural history is actually part of the problem, and the reason why we are not treating everyone and why governments are reluctant to put more effort into looking into this issue is that, first of all, not everyone who gets infected gets a chronic infection, and not everyone who gets a chronic infection actually develops cirrhosis. So there is a fairly large number of patients that will probably never really suffer from viral hepatitis, despite the fact that they, of course, are able to infect other people, especially when we're using at the intravenous drug user community. However, we do not have very good tools to predict which will be the ones that actually suffer, develop cirrhosis, and then develop cancer eventually, or decompensation, and which will be the ones that just carry the virus but never ever really suffer any trouble from this disease. And because we think that it's only maybe 20 to 30% that ever will get in trouble with this virus, governments or health departments are a little bit reluctant to treat everyone. On the other hand, we do know that curing hepatitis really reduces the rate of death due to liver cancer, due to cirrhosis, which was shown very nicely here in this study using old treatments, interferon-based regimens with fairly long follow-up, because if you cure the virus here, you have a very long life, and if you still retain the virus, it's not so good for you. This is liver-related mortality or transplant, and this is liver cancer. Now, times have changed because we don't have to use the old drugs, which were very cumbersome, expensive, and difficult to use, but we have easy-to-use drugs now. And for this reason, WHO came out, I think 2 years ago, or last year, with the WHO Global Hepatitis Strategy. And you can see the targets here. They set targets for hepatitis B as well as hepatitis C. And when we look at the targets for 2020, you see that they want to reach a 50% harm reduction in intravenous drug users. And in hepatitis B, they want to have 20% reduction in new infections, 50% reductions in new hepatitis C infections. And by 2030, they want to have at least 90% reduction with new hepatitis B infections and 70% reduction in new hepatitis C infections. And then they also have targets for reducing hepatitis B and hepatitis C related deaths, which will be both 60% reduction in viral hepatitis related deaths by 2013. So this is what WHO is shooting for. Now, what does the hepatitis C treatment in 2016 look like in Europe? Now, the drugs that we have are quite numerous. Those have been around for 2 years or 1 year, and the ones that have been approved this year do show one particular feature. They have been improving over time, but for the first time we really have a drug that works on all genotypes, and this is very important, especially when we look outside Western Europe, when we look outside the United States, where health services are not as well developed, and where it's more difficult to get genotype testing and also have the knowledge how to treat different genotypes. And this is what the recommendation is from the new EASL recommendations that came out this September. And what you see here very nicely is that you do have regimens that are actually active against all genotypes. So there's really no situation where you don't have a drug. For some genotypes, you have actually a whole range of drugs you could use. But for some genotypes, especially genotype 3, the options are more limited. Nevertheless, today, we can treat all the different genotypes very effectively. And therefore, the treatment indications, according to the European Association for the Study of the Liver, is that actually we should treat all treatment-naive and treatment-experienced patients with compensated or decompensated chronic liver disease due to hepatitis C. All of them should be considered for therapy, which comes down to actually universal access for therapy. This is what the European Association is recommending. Unfortunately, this is not what is the reality in Europe, and also not outside Europe. Now, when we look at what would be needed in order to really make an impact or a greater impact for viral hepatitis, there clearly is a need for prevention and screening. Now, the impact of screening we really only know from modeling studies, and the best ones here come actually from Great Britain, where the epidemiology is a little bit different from, let's say, countries in Eastern Europe, because first of all, the rate of viremia is 0.3%. This is very comparable to Austria, for example, but 90% of the patients that were infected after 1996 were intravenous drug users, and when we look at Eastern Europe, there's a lot more nosocomial transmission there. So the age distribution is what you would expect, between 20 and 50, and the projections for viremic individuals, they range at the moment, because this relates to how treatment will impact the epidemiology of this disease. Now, modeling was done where the base scenario was taken 2013, and then there was a stepwise increase in treatment according to fibrosis stage. I'm not sure whether you're really aware of this. Now, the damage to the liver is graded in different stages of liver fibrosis, and the treatment allocation in many countries depends on how far advanced the disease is, meaning that patients with F4 fibrosis, those are the cirrhotics, they're probably treated everywhere in Europe. And then in most countries also F3, the advanced fibrotic stages, are treated, while F2 is not really treated in all countries. In Austria it is, and F1 is not treated in many countries. Now, with regards to what I showed you before, the progression of the disease, this is probably something that can be justified, but when you look at it from a public health point of view and a infection point of view, considering that many of those patients are actually intravenous drug users, then it doesn't really make sense that you leave people that you know have an infection untreated. Now, in this modeling, they were looking at what would happen if you would increase treatment, but would not try to find more patients. And if you just increase the treatment, mortality, liver-related mortality, would still increase by 90% by 2030. This is the black line here. And a treatment increase with the new drugs by 115% until 2018 would lead to a 50% reduction in liver-related mortality. This is the red line here. But in order to do that, actually we don't really know all these patients. We cannot just increase the treatment rate by 115% because we don't know all the patients that we would need to treat. We would actually require to increase the diagnosis by 140% by 2018. Now, this also consecutively would lead to less infections, less cirrhosis, less cancer. And the only way to increase the patients to be treated is to screen for them, to look for them. Now, the diagnosis rate in differs according to countries. You can see that some countries, Australia most notably, but also Sweden, Finland, France, do already have a fairly good diagnostic rate, ranging between 70 and 90%. And Australia is so good because they also have this peculiar epidemiology where it's really confined to intravenous drug users, and they have a very aggressive approach of going out into the communities and really chasing the possibly infected people. They don't wait for them to go to the doctor. They're really going out there and search for them, and then they treat them. While in other countries, you can see, for example, Austria, we probably have a diagnostic rate around 40%, and of course there's other countries that are much worse where the rate of diagnosis is below 10%, and that's a problem. Now, chance for a comprehensive viral hepatitis plan. Now, when you look at the number of treated patients here, you can see that some countries are doing quite well, like Germany and France, and then other countries are not doing as well, that you can see here. And the annual treatment rate of the infected patients, even in those countries that are doing quite well, is below 10%. You know, France and Germany 7-8%, Austria treating around 4%, and then other countries treating many less. Now, having said that, we have to say that progress has been made in the last 2 years. Here, looking at the global numbers, you can see the number of hepatitis C patients treated globally. There has been a very steady number up until 2013, and then there was a significant increase in 2014 and a big jump in 2015, meaning now with the new drugs, really a lot more patients are treated on a global scale. And also, when you look at this in Europe, you can see fairly stable development. 2014, not even just a slight increase, but in 2015 was a big jump, you know, a large increase, about a fourfold increase or at least doubling, I should say, doubling of the patients in the last year. Now, one problem, however, that you see is that this increase is actually confined to just a few countries, you know, is not happening everywhere, not even in Europe, because you see Spain is doing fine, Italy is doing fine, Germany, France, UK is already not so good, and then the other countries here, you can see, okay, some of these countries are small, so they don't have a lot of infected patients, but there are also countries like Romania, for example, with a very significant number of infected patients, but still a very low number of treated patients. So this is something that is a matter of concern, and something that tells us that there is disparity between countries in the EU, and of course there's even greater disparity between countries on a global scale. And this is important because if WHO has set the targets to reduce the infected rate by 60% by 2030, it's really important that all countries participate here. Now, if you consider to really take action against viral hepatitis, especially in countries where resources are more limited, it would be really good to have a national viral hepatitis plan, because this, if you plan it, you probably will use your resources in a much more efficient way. In Austria, we always say we don't really need it, you know, because everybody who has a significant disease gets treated anyway. So it's true, linkage to care in Austria is fairly good. However, we're not really excellent in prevention, and we're actually not good at all in detecting patients. So even for us, it could make sense, but for many other countries, it would be a lot more important. Now, what are the building blocks of a viral hepatitis plan? Primary prevention, of course, very important. Prevention is always the most important building block. But then early detection before it's too late, before your patient has decompensated cirrhosis, is very important. And once you detect, you actually manage this patient. Now, this is something that sounds logic, but I will show you data that this is not logic in many other places. And then once you treated your patient successfully, this patient still needs follow-up, in particular if he's got cirrhosis, because then he still has a fairly relevant chance of developing liver cancer, even though he's cured. And this whole concept here is called the continuum of care, and this is what is at the heart of every national viral hepatitis plan. Now, here, this is the one thing that I wanted to show you when I talk about linkage to care. Now, this is not something in India, where it's actually much more pronounced. This is data from the US, you know, a so-called developed country, even though with regards to healthcare, this is probably not really true. Is when you look at all the chronically infected patients there, it's around 3.5 million. And when you look at the ones that have the diagnosis, that actually know they have the infection, then it's just 50% of those. And then access to outpatient care is still not bad for the ones that are diagnosed. But then when you look at of the ones who really know that they have HCV RNA, it's only half of those. And then when you look at the ones that actually are prescribed treatment, it's only 16% of all these patients here. And the ones that are healed is even less. You know, less than 10% of all infected actually achieve an SVR at the time that this was published, and that means old data, old drugs. So the SVR rate from the ones that actually are prescribed treatment would be now higher, would be around here 15% probably. But still, that means that even though we have a large number of infected patients, very few patients get treated, and even less patients get cured. So, to sum it up, Hep C is a disease of global importance. The prevalence differs in the EU between countries and across populations, from single-digit range in the general population to substantially higher in high-risk populations, in particular intravenous drug users. Hepatitis C treatment with direct-acting antivirals has become amazingly effective and safe. I didn't show you any data here because this is, I think, now common knowledge. And these regimens really work and are very well tolerated. But publicly funded access to treatment is very heterogeneous in Europe, ranging from universal coverage in countries like France or Germany to no access at all in some Eastern European countries. In order to make a real impact towards HCV eradication, more patients would need to be identified to increase the treatment rate. So finding the ones that are infected is of major importance to eradicate the disease. But of course, screening only makes sense if diagnosis is then linked to treatment, because just knowing that somebody is infected but don't treating him, well, that's not really helpful. National hepatitis plans are most helpful to facilitate a most effective hepatitis elimination strategy from prevention through early detection all the way to treatment and follow-up. With such plans in place and funded in many countries, the viral hepatitis elimination strategy proposed by WHO for 2020 and 2030 seems to be ambitious but achievable. But if this is not put in place, I think WHO will not get where it wants to get within the time frame outlined here. Thank you very much.